Dr. Vaiani is assistant professor at the Institute for Medical Humanities, and she's a former director of clinical ethics consultation services at UTMB, where she's involved in clinical consultation, teaching, and she serves as co-chair of the Institutional Ethics Committee. We're really excited about having her here to talk with us some about ethical issues concerning care and treatment for patients living with HIV. So Dr. Vaiani, welcome. Thank you.
Thank you so much. It's nice to be here with you all today, and I hope that we can have a bit of a discussion about some of these issues, and I can get some input from each of you about what the questions you have are, and inform how I can think better and more completely about these issues, since you are where the rubber meets the road, as they say. Do I have to read the disclosure? Oh, okay. Then the disclosure slide has been completed. Let me see if I can operate the, no. There we go. My topic, as we have already talked about, are ethical issues involved in HIV, both treatment and care. So we'll chat a little bit about that today. These are the objectives that I'd like to cover today, not necessarily in this order, but certainly I want us to review, as I'm sure all of you have heard and know, the 4 ethical principles that are basic to healthcare. But I'd also like to apply those issues to some of the cases we're talking about. So really work with these issues. The issues are not the be-all and end-all, because they frequently conflict. But I think it's important for us to know the language of ethics and to be able to say why our gut tells us there's a problem here. And so that we will do as we review some of the cases that will illustrate the issues that I have decided to talk about, list for you today. This slide is a little small for you to see, and I apologize, but it's really just a timeline of HIV, and from the very beginning of the epidemic, if you will, and I put it up there really to illustrate, among other things, how little we knew when it first started out, and how we have, over the past almost 40 years, really learned a lot, experienced a lot, but I think we will talk about how some of the fears and some of the misperceptions still persist, and therefore still are haunting our work and our patients. And I think very basically from the start, much of our issue was how is HIV transmitted, and a huge lack of understanding about how you can get HIV, and then secondly, how you can't get it, and what will not transmit the disease. But I think these 2 slides really show, to me, illustrate a lot of the misunderstandings from the very beginning. You know, can I get HIV from kissing, from touching, from, you know, a mosquito bite. Fill in the blanks. There was a huge fear and misunderstanding about how it was transmitted. I think before we even talk about the ethical issues, it's important to remember that stigma has, since the beginning, been a huge issue with our HIV patients. The disease carries with it many, many social meanings that affect the whole gamut of our patient's existence. It makes prevention, treatment, mental health care, support for the patients extremely difficult. I think this has gotten better over time, but I think it still exists, and to a great extent, I think it exists differently from many, many other diseases. And so is particularly pertinent to our patients. I think stigma, which is commonly tied to fear, produces prejudice, certainly negative attitudes, and I think that often extends into abuse of the patients, whether it be from the public or even from healthcare practitioners. That stigma of having the disease is quite upfront and something that we really, I think, need to always have in the back of our mind as we talk to our patients and as we counsel our patients. Because the numbers show us that 80% of patients that are HIV positive feel like they have been stigmatized in one way or another. And in order to prevent that, to deal with that, to be aware that that's impacting our patients' care and treatment, we have to ask them. We have to be aware of what their problems are. And so it's important that we really have that in the forefront. I think a lot of the fear of the 1980s persists today. I'm obviously old enough that I was around when this disease started showing up in our hospitals. I worked a lot of labor and delivery at that point in time, and I can remember doctors coming in spacesuits with gloves that went up to the shoulders to protect themselves from this dread disease. And so I think some of that still is around, even in our developed world. When you go to less developed environments, cultures, countries, you will find even more of misunderstanding. And so I think that we need to be aware we've made a lot of progress on one hand, but on the other hand, we've got a lot to work to do to really correct some of this. I have some pictures, and I must admit that a couple of the pictures, the two on the upper right, are from Ebola pictures, not HIV pictures. But I think they can illustrate some of the overreaction that we experienced in the beginning. And I think the picture of we need research, not hysteria, is a good thought that we can think about and it's often and has been through the HIV epidemic period always a question, and I think it remains a question in research today, is how do we get research to the people that need it in a rapid manner, but yet ensure that it's safe enough that the drug, the treatment, whatever the case may be, has been studied enough that it's not going to harm our patients. And I think that is always a difficult balance to achieve. The AIDS population has been very effective in demanding access to new drugs. And other diseases, other patient groups have really benefited from some of that activism. But it has also meant that drugs, treatments may be riskier than we would like them to be when they reach the public. So I think that double-edged sword is something that we always need to keep in our minds. I think that this sort of goes without saying. Stigma and discrimination can affect our patients in really serious ways. Their income, their livelihood, certainly their choices as far as childbearing and even marriage may be impacted by this. I think that to their perception, and I think we can certainly find examples of this, their health care is poorer than we might want it to be. And I think in the beginning, and to some extent now, caregivers are concerned about caring for patients with HIV and therefore exposing themselves. So, but I think some of the most difficult issues are the mental health issues, with the idea that these patients, even though HIV is now more a chronic disease than it is the acute disease we saw when it first came out, it's still a disease that is going to result in the patient's death. And that brings with it certainly a sense of, for many, hopelessness and worthlessness. And how do we counteract that? How do we bolster their mental health when it has taken such a huge hit? As I said in the beginning, one of our important roles as healthcare providers, I think, is to identify patients' issues with stigma and find a way, as this slide depicts, to empower them, to protect them when we can, to understand what their issues are, to educate them, but to help them themselves deal with the stigma that they are feeling, because it can come from many sources. But I think, as I said before, part of that is our recognition that it's still there, and how is that impacting the patient we're dealing with. The other huge issue that I think is important is HIV in correctional settings. And I found, as I did some of the work for this slide, that our numbers are kind of lagging. So the most recent numbers I could find were 210 numbers from the prison system, which is, in my mind, I think we ought to have more recent numbers than that, but that's what I could find in essence. But we do know that the United States has a great number of incarcerated people, and in the prison system, we have a great deal of patients who are HIV positive. And so dealing with those patients and treating them is a challenge. They're certainly a vulnerable population and stigmatized for a whole lot of reasons outside of their HIV. And then to add that burden to their burdens, if you will, is even more adds to their vulnerability. And so I think it's important always to keep that in the back of our mind, because it's really a collection of HIV patients that is much larger than the general population. So for that reason, I think it's very important for us to remember that. I'd like to spend just a few minutes talking about the core ethical values. And here, this is a review. I'm sure all of you have heard, seen slides that depict the four sort of basic ethical values that we talk about. Respect for others is, I think, the first and overarching value that we want to talk about. Many times you will see this sort of reduced to autonomy. Do you hear that more often than respect for others? Autonomy is the ethical value. And certainly individual autonomy, individual choice comes from the value of respecting others, respecting that patient's rights, values. But the respect for others, I always like to mention, because it's much larger in its concept than just you have the right to pick and choose, which is the basis of autonomy. So it's really, we respect others by letting them make their choices, but it's bigger than just making choices, if you will. So, and out of that comes so many of our important tenets of ethics, such as informed consent, privacy, protecting the patient's privacy, confidentiality, truthfulness, honesty. All of those tenets come out of this first ethical value of respecting others. The second ethical value that we will talk about today is beneficence. And beneficence means basically our obligation, certainly when we apply it to healthcare, it's our obligation to promote the health and well-being, the quality of life, curing a patient, treating a patient, prevention, but it's in essence to do good. You know, we want to do good for the patient. And so that sort of undergirds all of our care for the patient. And this balances our ability to do good, balances against the patient's right to refuse our treatment, to refuse our wishes to do good for the patient. So that kind of illustrates how the values, the ethical tenets conflict and don't often give us necessarily an easy answer to our questions. But certainly, you know, our goal here is to promote benefit to the patient. What is in our patient's best interest? What can we do to make our patient better, if you will? This is balanced against the third ethical principle, non-maleficence. Lots of words, difficult to pronounce, and it basically means do no harm. You know, we want to make the patient better. Sometimes if the patient has cancer, we can make the patient better by giving them chemotherapy. Chemotherapy has a whole lot of harm involved with it. So what we're doing here, and that's true with other things, there's often benefit, but it comes at the cost of some discomfort, pain, maybe even more illness in the time that we're trying to get better. So we're always trying to balance. We give chemo because we think we can cure a patient. So that's the balance. But it's often in all of our care and treatment for a patient, we should be balancing that. We may not necessarily be making a good list and a bad list, but there is harm and benefit in almost everything we do. And we need to be thinking about that, and our patients also need to be thinking about, for them, in their life, in their quality, their conception of their quality of life, is the benefit worth the harms? And so that's what we are concerned with when we talk about non-maleficence. The fourth ethical principle is justice. And justice is the bigger picture, is how I usually describe it. We're looking to make sure that our treatment is as fair as it can be, and that our care may not be the same, but it should be as equitable as we can make it. We all know that there's a lot of injustice in healthcare. It makes difference whether you have insurance or not. It makes a difference whether you can pay for your care or not. But in general, the bigger picture is that we would like to have access for all. We would like, certainly, for vulnerable populations not to be discriminated against. In addition to being vulnerable, also not being able to get care. So a lot of this is at a mega level, but we also see justice in our individual clinical lives as we think about which patients get access to certain research protocols, which patients get access to, free drugs, all sorts of issues that bring this down to our level. But from the ethical point of view, individual practitioners should not be put in this situation where they have to decide patient A gets care, patient B doesn't. We're supposed to be here to give care to all our patients. And so justice really, trying to preserve justice sort of challenges that many times. Okay, let's talk about, and this is certainly not a complete list, but it's just some of the things that, as I went through the literature, seem to be issues that haunt HIV patients and their caregivers also. And so confidentiality, disclosure, duty to warn, kind of lumped all of those together. Disability rights, medications and treatments, surrogates and advance directives, employment rights, economic issues, and suicide. So I'm going to try to fairly quickly cover the basics of some of these issues. Confidentiality is another one of those sort of double-edged swords. We are required, both legally and ethically, to keep health information of individual patients private. That's part of the trust between a patient and their caregiver. But there are obviously boundaries to that. And in this case, we are also, as physicians or their designees, are required to report HIV and AIDS. So obviously that confidentiality isn't total. Our patients need to understand that that diagnosis, just like many other sexually transmitted diseases or communicable diseases, are required to be reported. And so it's total confidentiality cannot be guaranteed for our patients. And sometimes that is a problem and can certainly interfere with the patient's trust in their provider. Disclosure. Each state has differing rules for disclosure. So I can't really give you the answers that are going to work in any situation in any state where you may be. But in Texas, we have some interesting approaches to HIV disclosure. We do not have to have a specific written consent for a patient to be tested for HIV. If they have signed a general consent form and we have verbally told them that we are going to test them for HIV and documented that. So there are some that feel that that's kind of stretching the idea of informed consent, but right now that's how our law reads. So that is what is the case now. There are also laws that dictate that pregnant women are tested during their pregnancy unless they object again. So how that's really handled depends on how whether we could even consider that some kind of informed consent. If we tell a patient, oh, we're going to do a bunch of tests on you, you know, urine tests, blood tests, we're going to do some electrolytes, and is that okay with you? I wouldn't necessarily call that my best idea of what informed consent for HIV testing is. So a lot of it depends on how it's handled. But anyway, that's our law. The notification to partners of possible HIV exposure is generally handled by the health department. The law actually reads that a physician may notify the wife or the spouse, I shouldn't say it that way, the spouse of a patient of the HIV status. But in our hospital, and I think in most places, maybe that's stretching a little bit, but in Texas, that's usually not the case. The doctor's not the one that's informing. It's handled by the health department under their reporting. We do require, as I think every state does, that patients that test positive get post-test counseling. And again, that can be handled by the health department. They have people specially trained to do that. In addition, and this is a question sometimes that we have actually gotten from some of our adolescent clinics, minors in Texas can give consent for HIV testing and other sexually transmitted disease testing. And so they don't have to get parental consent for that. So that's kind of a interesting quirk, if you will. Duty to warn. Do we have a duty to warn? Do we? How do you define a duty to warn? You what?
I just looked it up.
Oh.
You want me to read it?
Sure.
The duty to warn arises when a patient has communicated an explicit threat of imminent serious physical harm or death to clearly identified or identifiable victim or victims, and the patient has the apparent intent and ability to carry out such a threat.
Okay.
That actually was the first time I've seen it.
Mm-hmm. Yeah. The duty to warn is, and it's exactly what you have read to us there, but it comes out of a California case, the Tarasoff case, and it had to do with a mental health professional. And he, I think it was he, had a patient who threatened to kill his, I think, former girlfriend is what the issue was. And the mental health counselor felt like he had the intention, and the means to do that. And he even had his patient hospitalized for a while because he was a danger to others. You can always, work that out if you're a mental health professional. But the patient got out and ended up killing his ex-girlfriend. And the case went to court, and we had this Tarasoff decision where it was said that if you have clear danger to a particular person, then you're required to report that. Unfortunately, Texas does not apply the Tarasoff. So there is no duty to warn the individual as there is in the Tarasoff. What we are required to do in Texas is to notify either medical or law enforcement personnel. I can't tell you that my patient has threatened to kill you, but hopefully by telling medical personnel and law enforcement, I can provide you protection in Texas. Mm-hmm.
Could you tell the law enforcement the means?
Sure. Yeah. In the duty to warn, that's all information that you, in order for it to be effective, it needs to be.
I actually had a patient that threatened to kill his parents, and I notified, he was actually getting mental health issues, of course, but I notified the authorities in the area where I was, and they said unless he actually attempts they couldn't do anything.
Mm-hmm.
Why don't you just call MHMR? I call MHMR, and they told me, just send the patient down here to our clinic, and we'll see them.
Yeah, you can't be sure the system works just because there's a system in place.
Mental health deputies say he's a danger to himself and others.
Yeah, and that's what happens often is they hospitalize the patient. The other thing that sort of operates when we talk about HIV and duty to warn, I think that's a little different than I have a gun and I'm going to kill you. Yeah. You know, and is it a specific threat to a specific person? And so that in HIV law makes it a little, even in states where there is a clear duty to warn, it's still kind of a more difficult case to make that it's the lethality that a gun or knife or something like that has. So just illustrates that Tarasoff is well known, and but it's important to know that it doesn't apply in Texas the way it does in other states. I think in disability rights, there's a lot of this is awareness. And awareness for our patients, help our patients know that some of these things are not okay to happen. And it's not okay for the lady at the grocery store to put on latex gloves as she checks your patient out. That's not okay. It's not allowed by our law, and somebody needs to correct that. And so part of this is giving our patients the knowledge and the support that they can address some of these issues themselves. And just a conversation with the grocery store manager that this is not appropriate behavior, we may be able to empower our patients to have those on their own and not come to the point that you have to file a legal case to accomplish that. Medications and treatment, side effects of treatment, all of these can affect our patients' ability to comply with a treatment plan. And how complicated are the treatment regimens these days? Better than they were, but how many pills are they taking a day?
One instead of 18 like you used to.
Okay. And so that's great if it's improved that much. And side effects? Less than before. So I think we've gotten better with that. But certainly, there's still some of the issues of patients that may interfere with their ability to really comply with the treatment regimen. And on top of that, they may just be dissatisfied with their care. They don't like going to the HIV clinic. We used to have an HIV ward here. And, you know, that sort of further stigmatizes the patients. And so it may be a source of discomfort for them. I think this is an issue where we can really help a lot of our patients. These patients, as I said before, even though they have a chronic disease, their disease is most likely going to kill them. And so it's important for all of us, and certainly someone with an eventually terminal disease, to think about end-of-life care and what kind of care we want at the end of life. And so having those conversations as part of your conversations with the patient, I think is a good start. And we need to develop comfort with having those conversations and not having the patient immediately assume that they're dying in the short term versus the long term. And for patients that are stigmatized in one way or another, whether they be prisoners, whether they be patients with same-sex partners, whatever the issue may be, these patients particularly may have a reason that their next of kin may not be the person they want to be making decisions. And but the law says without written direction appointing someone else as their decision maker, their next of kin will be making, is legally allowed to make medical decisions when that patient is no longer able to. So these patients particularly, we need to talk about medical power of attorneys. Who do you want to make decisions? And let's make some paperwork. So that's who will be given the right to make your decisions. And so that's always a conversation that's a worthwhile use of our time with these patients. Employment rights, often HIV patients have to think seriously about whether they can continue in the work they were previously doing due to risk. And but beyond that, it's also eventually they're going to have health needs that are going to interfere with their work, their ability to do their work and to remain employed. And I think that is a significant issue for many patients. They get a great deal of personal worth out of the work they do. And when they can't do that, it adds to the burden of their disease. So I think, again, we need to recognize that as an issue. Economic issues, financing treatment, and certainly issues, as I talked about with employment, not being able to work at times may affect their health care coverage. We haven't seen it so much in this country, but certainly in underdeveloped countries, in countries in Africa where 40–50% of the population has AIDS and parents are dying. They're orphans, AIDS orphans, that really are there in great numbers and need to be cared for. And so those are certainly economic issues that are concerning. Suicide. People living with HIV have significantly increased frequency and severity of both suicidal ideation and thoughts of death. And all the things we talked about previously are some of those contributing factors. I think, again, for us as health professionals, it's that like advanced directives teaching needs to be part of our evaluation of patients on a regular basis. What is their current mental status, and how at risk for suicide are patients? So all of those are things that are important to think about. Okay, now we'll finally got to the cases. One of your clinic patients is a 35-year-old man with AIDS on Medicare who is an active intravenous drug user. He uses heroin and cocaine, but he never shares needles and is reliably present at all his clinic visits. He admits that he is often unable to take his medicines regularly when he is using drugs. He is asking about antiretroviral therapy with protease inhibitors. You have just read that HIV viral resistance to protease inhibitors occurs rapidly when patients are unable to take their medicines. What do you think about this case? You're the doctor. Should this patient be prescribed? Okay. No, why not?
Because if he, becomes resistant to it later on, he may decide to quit his drugs, and then he may want to take it. And if he does, he may already be resistant.
Okay. So tell me in ethical language why you chose not to prescribe him this drug.
Because it would be misused. You mean you want me to go and
Are you saying that it's harm? The risk of harm is greater than the risk of benefit for this patient to take this drug?
Not necessarily.
Okay.
It's kind of up in the air. What I would do, I would just tell him the benefits that the drug would have, and that if he decides that he wants to take it, and he continues his drug use, that later down the road, if he decides, to not be doing drugs and wants to try to get well, which it very well will help him tremendously, that it may not help him at that time. So I would ask him to make a choice.
Okay.
Do you want to do this knowing that down the road, if you decide to quit drugs, that it may not help you? Or would you just rather wait and you make the decision to stop and use this drug that's going to help you?
Okay.
And so I would just put it to him like that.
Good. Yes, ma'am.
I think the ethical word I would use here would be justice or fairness, because if he's inquiring about the drug, I'm assuming he's already researched the medication. And patients that do have drug-resistant HIV, most drugs, you can develop drug-resistant organism, to the virus. So they're usually going to be on more than one drug. So even if he took this, I would look at prescribing, having other medications, in that little mix, and letting them know, just, educating the patient, these are the adverse effects, this is what could happen, but, treating them the same way, regardless of their drug use, just like I would treat the other patient that's diabetic, that's insulin or whatever. But I would do the same.
Another thing that I would do is try to get him the help to come off of the drugs. Would be like a plan. This is I want to work with you, and this is our plan, and this is how I can help you, come out on top, better for your health.
Okay, all around. Yeah. So
kind of give him something to look forward to. If he needs help with, psychological help. Go to get off the drugs and have like a plan with him. Okay, this is what we're going to do, and then we're going to do this, and then, where he has something to kind of gauge it and look forward to being completely cured as possible.
I don't know if Galveston has anything, but I work some with the mentally ill and the homeless in Houston, and they have a Thomas Street Clinic and Legacy, and they do a lot with the HIV and mentally ill. Yeah.
We have it.
Yeah. But I think you're right. It's very difficult to treat his HIV and ignore the addiction. And so it's got to, I like your idea that it's got to be a more broad-based plan and to involve the patient in that. Any other ideas about this case? Okay. I think I have another one. Case 2, can you read that? Somebody read it for me.
You are taking care of a 40-year-old gay man with AIDS who is intubated with his third bout of pneumocystis pneumonia. His condition is worsening steadily, and he has not responded to appropriate antibiotic therapy. The patient's longtime partner, Richard, has assigned medical power of attorney and states that if the patient's condition becomes futile and the patient would not want ongoing ventilation. The ICU attending physician decides that ongoing intubation is futile, and after talking with Richard, he decides to remove the patient from the ventilator to allow him to die in the morning. Meanwhile, the patient's Roman Catholic parents arrive from Kansas and threaten a lawsuit if the ventilator is withdrawn.
Okay. You're the nurse in ICU. What are you going to do?
Patient's wishes were to be removed. He had a signed medical power of attorney that went over to his state and mind. Therefore, you go by the patient's wishes. If he signed it, that's what you would carry through. I mean, if they would have, if the patient placed Richard as his medical power of attorney to make the decisions, I mean, they have no. I know there's probably been. I know there is that law about the brain dead young lady, the one with the parents. They come in and she was on the ventilator and they wanted to remove her in the state and all this big mess back in the, years ago. But I mean, that's the law that it's signed. I would assume so. I mean,
well, I think that since his parents have just arrived, I think that if he's in the hospital, that, ethics needs to be involved. And maybe
call the ethicist.
No, really, it's his parents. I mean, they may only need one day.
Yeah, but it's not about his parents being there. It's about because legally it goes to the parents if he's not married. But Richard is his partner, and since they probably couldn't be legally married in the state of Texas, then the medical power of attorney was signed over to Richard from him signing it. If you have a signed document for it, I understand to get ethics involved because it's going to be an argument. But in the long run, I mean, we hope they can come to some agreement. But Roman Catholic, I mean, I get to see that right there how that's going to turn out. They probably haven't even seen Richard, the guy, and you don't have his name on there, the 40-year-old male, in probably years because he's gay, So, I mean, that's an assumption, but I'm just saying that that's the true reality of that, though. So,
by law, he has the right. So.
Mm-hmm. I think, and I think I have some questions here, yes.
I'll tell you one thing, going back to the other thing.
The other slide?
With the diagnosis, I think all risk factors need to be addressed because you're assuming he got HIV from either a needle or gay, or that activity. We just assume that, so we need to address all risk factors,
Mm-hmm. Well, we need to not make assumptions. Yes, absolutely. Yeah. Okay.
Well, I just have, I guess, a softer heart, and I would just give the parents.
I know I'm a parent too. I know it would be hard as a parent, and then of course as a nurse, and then seeing all these. But legally, I mean,
yeah. And that is sort of the trump card. It's if and the case leads us to think that Richard is the legal decision maker, and so. And it's even more important, if you notice in the case discussion, that the case presentation is that the patient would not want ongoing ventilation. So not only is he making a decision as the legal decision maker, but he's also saying that this is the patient's wishes. So we have a strong reason for that to be supported.
The power of attorney isn't the same as the advance directives as well. I mean, as far as for what types of things they would want done with them, like to be, intubated or to be like life-saving. So they're not the same. So I would hope that as a nurse we would advocate that if they didn't have one on file, the care manager would advocate to have them both on file for that patient. So you know what that patient's wishes is.
Well, actually, and yes, I'm not challenging what you say, but there are different types of advanced directives, and there's an advanced directive where you can, the living will, or has a much longer name, but where you can say what you want and what you don't want. The problem and the reason that it's better to have a medical power of attorney is because there's so many issues that can happen.
No, I mean,
so
having both of them, like the way the patient would have said what he wants done in the case that I can't, breathe for myself or I'm brain dead, have that, but I'll encourage him to have that. But if
exactly, but the best thing for you to have is a discussion with that medical power of attorney about what you want and what you don't want in situations. So he can apply that versus, a written statement that says, I don't want the ventilator, or maybe, I think that's where people sometimes make, mistakes. I never want a ventilator. Well, do you really never want a ventilator? Or do you want a ventilator if you have pneumonia and you'll be better in 3 days? I think I want that ventilator.
It's also like feeding them also when you have an elderly patient and they're not eating anymore and they're like, those are part of
Sure,
it too.
all of those are huge questions. But I think, in this case, we have a legal decision maker, but we also have a lot of social issues. We don't know what this patient's relationship with his family. Has he not talked with his family for years? How can we handle them in a way that's compassionate? Who can help us do that? And maybe it's the chaplain, in this case, and explain to them that, this is what's going on. This is who the legal decision maker is, and we appreciate and we sympathize with their feelings, but this is what their son wanted, and we're ethically obliged to do that. So I think while we clearly want to do what's right, I think we also have to attend to parents and to their emotional needs, where we can't give them what they want. Their threat to sue is, a useless one. So, but I think we still have to acknowledge that they are the parents and they may have some real issues here that will persist long beyond their son's death. So let's see if we can't help them get over this. Okay, did you have a question?
No, it seemed to me like it was a pretty clear-cut case for the medical side. Like there's a person who holds power of attorney, medical power of attorney, and so it's up to Richard to kind of negotiate the social conditions, and whatever he ends up deciding is what you as a medical team should provide. But your point is that even if that's what you provide, don't forget that it might be difficult for other people, and be kind and do good where you're able to.
Exactly. And not only the parents, sometimes this is hard for practitioners. There are a lot of practitioners who are very uncomfortable in situations where we withdraw support or we decide not to provide ongoing support. So be aware there's a lot of feelings involved here, and we want to deal with all of those. I'm getting pretty close to my time. Can I continue, or should I?
I think for those that want to stay to wrap up,
Okay.
Definitely.
We have one more case, and we'll do it quickly. How's that? If anybody has to leave, that's fine. Your 36-year-old patient has just tested positive for HIV. He asks that you not inform anyone, including his wife, of the results, and claims that he is not ready yet. What do you think? Pardon?
I would respect it and have further discussion and elaborate more. But, it's something that would have to be addressed, but he may need his time to absorb it.
Okay.
I think it depends somewhat if he's adherent or not. If he's adherent and drives his viral load down and he's not posing a threat to his wife, then that's one thing. But if he's not adherent and his viral load is high, then she's at a clear risk of horizontally transmitted HIV, and that I think should provoke a duty.
The county's going to be informing her before it's figured out whether he's adherent or not.
Yeah, that's true. Yeah, right. So it's very exciting.
Yeah.
Well, and I think that's a lot of what enters into this, is that we're required to report. So they're going to do their investigation regardless. And so I think it's important to talk with the patient about what's going to happen. Even if you don't tell, can't tell you exactly when it's going to happen, but your wife is going to be contacted. And so it's probably going to be a whole lot better for your relationship if you tell her before that happens. And so I think those are conversations, but patients may need a couple of hours to figure out how they're going to approach that, how they're going to proceed. And all of the questions, all the comments that you made before, what is his plan for continuing to have sex, unprotected sex? What is her risk? And how do we explore some of those issues with the patient, help him resolve those questions he has, and help him come to the realization that the best thing for him to do in this situation is to tell the wife himself, and sooner rather than later. And so I think we're asking our physicians, our nurses, our counselors, care managers to be really, really skilled in having these discussions, which are impossibly hard discussions to have with patients. So how to both do what's right, but also provide your patient with the best resolution that is going to benefit him the most and harm him the least, but also having the concern about others beyond your patient, the justice issue. How about the wife? How about the Roman Catholic parents? There are lots of people that are involved in this, and although they may not be the decision maker, or they may not be the one that is knowledgeable at this point, how is it best to proceed in this particular situation?
And the wife may know she's positive.
Yeah. Yeah, it could be. It could be. Yeah, the wife's positive and she never told him. Yeah, all of those are issues that I'm sure many of you have seen in the clinic settings. Okay, I think that's it. The other are just references. And are there any questions? I mean, I'm sorry we ran out of time, but I think the cases were hopefully fun and illustrative. How soon it has to be reported? Let me check. I may have that. I don't know off the top of my head, but I have a little cheat sheet of Texas laws I think I have with me.
I volunteer information just in your
Oh, awesome.
surgery
Awesome.
with like questions you'll ask.
I don't see a time on there, but that is, it may be in the small print.
Well, I was scared the last time I said,
I imagine it's probably in, some,
last time experience.
yeah, in a reasonable manner. You can have that if you want.
You're going to buy yourself about an hour interview with a surveyor if you check out or do something.
Well, that's the thing is when I have the agency.
It doesn't
I'm
matter.
like, it doesn't matter. It doesn't matter. We all rise together. We all fall.
Exactly. We either